Good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, back with you, broadcasting live from the Dolph Simons family studio. We've got some great guests with us today. On my right, of course, Hawkeye, as he's always here. On my left is Maria, I'm going to say it right this time, Adjemian. All right. One of our dentists that are here working with us, does a great job down with Jayhawk Primary Care and at KU Dental. And they're part of our Department of Plastic Surgery and Oral Facial Surgery. And that is led by Dr. Richard Korentager, who's a gentleman who's got a mask hanging off his ear. And he is, there he goes. I knew he heard something about that. So Richard is an outstanding plastic surgeon who's the chair of our department, and together we're going to have a conversation about, is it safe to go back to the dentist? Because we think it is. Is it safe to see a plastic surgeon? I don't know if it's ever safe to see a plastic surgeon. Just kidding. But we'll start with Hawkeye.
Yeah.
So Hawkeye, it's kind of a bumpy weekend.
It was a bumpy week. Our numbers were up and down here at the health system. Today we are on 36.
Yeah.
With 9 in the ICU, 3 on the vents.
It's a little higher than what we have been running.
It is a little higher. The concerning thing is last week we had the same amount of acute infections as people who recovered. You know, right now we have more acute patients, 36, compared to about, I think, 26 that we're considering are recovered. So some of those patients obviously have gone home. The more concerning is the number of admissions, though, which has been great.
Yeah, it's been high over the weekend. Just to say, so that's 62 total COVID patients in a hospital bed, or even if you take care of both the acute and the convalescent are recovering. So 62 is a big number of patients in a hospital bed with COVID alone. And that rise makes you a little nervous because we know that schools and colleges have reopened, and we'll come back later this week with some statistics to talk about what the changes have been in our population. Because I think it'll be important for people to hear and see that, to know what kind of folks we're admitting here to the hospital. It's also true that our death rate is hanging in around 9% here in the hospital, between 8 and 10%, so right around 9%. It's been that way for a number of months, ever since we really got our core therapies up with Decadron, Lovenox, and Remdesivir. Little harder time getting convalescent plasma right now since the government decided to issue an EUA. It made it harder to participate in the trial. And then over the weekend, the FDA kind of said, "Oh no, finish up your trial doses of convalescent plasma, and then put the EUA into effect." So help us sort through that confusion a bit.
Yeah, you know, there's been an amendment. There was amendment. A lot of it was due to technology that the blood centers that people were getting their plasma from, they had to actually start to quantitate the amount of neutralizing antibody in the plasma. They had always been asking.
They didn't have that technology, all of them.
Correct, yeah. Kind of still, I think it's going to be difficult for a lot of them to get that. We have been really, or the plasma donation centers have certainly wanted plasma from more ill patients, say patients that had to go to the hospital or recovered from critical illness, because it's believed you have an increased amount of neutralizing antibody. So this way, moving forward, they will be able to detect it. But just as you said, right now, I believe there was an amendment saying continue to finish the donations of plasma that you got during that investigational period. We will be working with our therapeutics group here this week to really formalize a plan for that and utilize, because there have been a large outpouring of people who have recovered from COVID in the city, in the community, who have donated plasma.
So in the long run, it may be a good idea to quantitate those antibodies so we can see how many you really have to have. Also, some reports over the weekend about more patients who are getting infected a second time.
Yeah, so this is interesting. We still, again, don't know. You know, very early on, we always said, well, just because you've been reinfected, that doesn't give you license to go out and meet in large groups, to go out without a mask, to go out and be closer than 6 feet, because we don't know. We assume you get immunity. We just don't know how much and for how long it lasts. And now what we're seeing in some of these reports are that people are testing positive again after about 120, 140 days. And it looks to be genetically just a slightly different virus than the other one. Again, there's no other clinically different strains from each other. They are using very fine-tuned technology to look at the genome and even delineate 1 to 2 different base pairs from these other strains. However, the first case from Hong Kong, that patient wasn't ill. We know that from some of the animal models, the rhesus macaque models, that when they are re-challenged with a virus several weeks later, They do replicate the virus, but they don't really get ill. So the other question is, if you do get reinfected, can you still spread the disease, and will you have symptoms of the disease?
Yeah, and I think the patient in Nevada is sicker the second time around, and so I think what we also have to remember is that some people don't do as good a job on an immune response. We know that there are infections that some people just don't mount antibody response to for whatever reason. And I think when you have millions of people now who have been infected by SARS-CoV-2, there will be some people who are going to struggle with that immune response, which means you have to stay safe, which means you still have to go to the dentist because you got to get your teeth taken care of. You don't want to get infections in your mouth. You don't want to get an oral abscess. You don't want to get an infection on your heart valves if you waited too long to go to the dentist. So Jimmy, talk to us a little bit about the things that are being done in the dental office to make sure patients stay safe.
Yeah. Well, we really started preparing when the pandemic started. The ADA had issued guidelines for us to start working.
And that's the American Dental Association.
That's American Dental Association. And we have to prepare pretty much like here with a stricter PPE. So we need to use N95s, surgery mask, goggles or glasses, and a face shield. One of the other most important things is that we're screening the patients before they come to the office. So we usually, some of them get an online questionnaire, or sometimes we get a phone call and ask them some questions. Our waiting room is completely different now. We have obviously a separation between patients. We cannot have a crowded waiting room anymore. There's no magazines, there's nothing to do in our waiting room other than just come in, get your temperature check, and get into our procedure room. In certain offices, we have put some air filters so we can bring the droplets down very, very fast. And obviously our cleaning, that has always been there because we've always been taking care of infected patients.
Yeah, well, that's true, because this isn't really new. The dentists are around people who have their mouths open, and when they have their mouths open, they're breathing, and they could be having particles come out.
Yes, absolutely. And of course, we have a high suctions that is going to help with all the aerosol that we're producing, and all our assistants and everybody in the office are wearing masks and shields and are very protected, because we need to protect the patients, we need to protect our staff, we need to protect ourselves too.
So have you had examples where patients have gotten sick in your office or contracted COVID-2?
No. Okay. I mean, I know people that had COVID, but it's not from a dental office.
Yeah, that's right. I think it's like coming to the hospital now. It's probably never been safer from an infectious disease standpoint than it is right now.
Yes, it is, because we're making sure that our rooms are clean before the patient comes in. We take all the precautions, and then we clean as soon as the patient leaves. So they are really very minimal risk, I think.
Yeah. So, Richard, you guys do a lot of head and neck surgery and flaps and reconstruction and all that. You're right around the sinuses you're operating. I'm guessing you all are keeping safe, too. Tell us about that.
So, absolutely. We have been very, very careful, right from day one. And actually, before I even start, I just want to say that, I'm sort of walking the walk. I went to Dr. Ajamian for my dental checkup, which was way overdue, and felt completely comfortable with, the protocols that they have in place. And that was just about a week and a half ago. So, within our group, we certainly do have surgeons, both from an elective reconstructive perspective as well as from trauma, where there is a lot of potential exposure to the respiratory tract. And we're exceedingly careful, as you say, the N95s. We follow all of the health system protocols. Any time that it is possible, we are absolutely making sure that the patients have been tested preoperatively, and as well that they are completely asymptomatic, because that's our biggest concern.
Yeah, that's great work. And I'm going to ask you the same question. Are you aware of any patient who's gotten COVID, either from in one of the plastic surgery clinics or anywhere else around here?
No, and obviously, since we're a teaching hospital, we've taken it very seriously with our residents. We went through a period where we sort of cohorted our residents because if there is even the least concern, we're quarantining people. So I'm not aware of anyone who contracted COVID as a result of any of the procedures that we have done or within our plastic surgery team.
Yeah, that's really good news. You still have that thing hanging off of your ear. Is that a medical device?
So I was trying the sound check. I'm one other person in the room, and we're more than 6 feet away. So we sort of felt that it would be safest and easiest for people to understand me.
Yeah, I have to laugh, but we're not recommending that masks work well with hanging off of an ear. Right. We're not sure that that's the best technique.
No, they tend not to be effective in that regard.
Yeah. All right. Well, Jill, let's see what questions might be out there this morning from media.
Hi, good morning. It's Taylor Himmons from Channel 441. How are you guys?
Good morning. How are you?
Good, thank you. I had a question about a story I'm working on because I saw a report out of Arizona last week about wastewater testing. Specifically, this report was for a college dorm, and I thought it was pretty interesting. And one, I wanted to ask if you guys had heard anything about the viability of testing wastewater, and two, if you know any place here in KC that employs that method.
That technique, okay. Well, we've talked, but we know that people do wastewater testing. Usually, if they can't do good surveillance testing on the students, they turn to looking at wastewater testing, because what happens is in our feces, in our stool, COVID-19 is secreted. Now, we don't think it's a live killing the kind of virus that's going to reinfect people, but it is there. And so you can then go find out if there's an early exam. It is a sign that somebody in a dorm or in a congregate living situation, be it a dormitory or a nursing home or where have you, does have COVID-19 in it.
Yeah, so we know that the receptors for the virus are in your GI system, so in your gut. We know that the genome, the virus, can be detected in your stool, and that does leave the potential for fecal oral transmission. That is something that is similar to other GI illnesses, particularly when you think of daycares and things of that nature, when people have stomach bugs and they run through a daycare, or even potentially run through a household. So we understand that you can detect it in stool. There is the potential for fecal oral transmission, but as of yet, they really haven't been able to culture replicate competent virus from the stool.
So virus that can infect somebody else.
Right, and there hasn't been really any cases identified with a large outbreak due to fecal oral, the same as, say, another norovirus or some other GI virus. So,
which clearly live in the stool and can be infected from one person to another. Yeah, and it's interesting. I don't know of anybody that's doing it in Kansas City, because at least at KU we know that we've tested everybody, or in the process of finishing up testing everybody, and that has been our way about trying to keep that campus safe. So I don't know about. Do you know of anybody doing?
I want to say almost. I think Lawrence maybe is.
Lawrence, the community is testing. Are they testing the college, or where are they testing?
I think they're just testing the wastewater. I don't know the full details.
Was involved in a study.
Okay.
Yeah. So let's talk to
that up.
Yeah, we'll talk to Tom Marcellano. He is the medical director over at Douglas County Health.
And from what I understand, you aren't getting able to break it down to a specific building. It's a large area of the community, whatever that may be. So
okay, we'll follow up on that question with you tomorrow, because you'll be on the phone with Thomas anyway pretty soon, I'm sure.
But the bottom line is we really don't understand it and really don't have evidence of, say, fecal to oral transmission as with other food-borne illness or other GI bugs.
But it is a surveillance technique, so you could try and find it and at least identify it in some general area. Then you have to go back and figure out which area it came from. Yeah. So it's like a massive pool of saliva, only it's not saliva that we're talking about. And did you want to ask a follow-up question to that?
No, I was glad you guys had, because like I said, this study out of Arizona was a dorm on the campus that they were doing. They were able to identify some cases, and it talked about what they did pretty quickly to kind of isolate those people and that kind of thing. So I thought it was interesting, and may see if I can find someone doing it here.
We know that very early on we were able to detect it in stool. I mean, even the studies from China and South Korea. And even in some of the cases, even with children, they detected it in stool longer than in the upper respiratory tract. So, but again, luckily we haven't really denoted or found any large outbreaks or even infections from that.
There you go. Other questions from media? Not hearing any, Jill. Let's turn to our listening audience today.
Okay. Cindy wants to know if the dentist could reconcile a report from the ADA and the WHO, the World Health Organization, because they seemed a little bit in conflict with the World Health Organization saying don't go and do anything except emergency.
Yeah, that was an
Right.
older recommendation. I think currently it's changed a bit.
Actually, the recommendation from the World Health Organization came about on August 11th.
No, I thought it was like in June, but they actually made that same recommendation in August.
Right,
Okay.
in August. So the ADA obviously doesn't agree with it because we are essential healthcare providers as well. And like you said before, if patients are having another comorbidity, another disease, and they're not going to the dentist, they can be affected. They have a higher risk to have periodontal disease, decay, and infection. And if we wait too long to see them, then they can get a little more complicated. And coming to the dentist regularly, we can prevent to have those bad consequences of an infection. That's why the ADA response that was the next day said that we are essential healthcare providers, and essential means we can treat and prevent any infection in the oral health.
Well, I think the other key, if I remember the World Health Organization thing, so correct me again if I'm
Yeah.
wrong here, if you have the right conditions, you can really be safe, and so you should go get that addressed. Even I think the World Health Organization would agree with that.
Right.
And I think what we're saying is that our dentists, at least here at KU, and I think throughout the United States, really are working really hard to make sure people stay safe.
Yeah, we did. And I mean, we were closed probably for about 6 weeks from March to May. And after that, we have seen an increased amount of patients coming to the office. And a lot of people are coming to the office. And like I said, we haven't seen too many cases.
Yeah.
So it is safe to come compared to not safe to stay with an infection in your mouth.
Yeah.
Well, I think that's the key, because you get a dental infection in your mouth, and that can lead to some pretty bad consequences.
Yeah.
We know that endocarditis results if you have a dental abscess, and you, which is what happens if you don't go see the
Right.
dentist. You have a tooth infection,
Yep.
and that gets into your blood and can get onto your heart valves, which is a difficult
Yeah.
place to have an infection and hard to treat.
Yeah, absolutely. So we do understand that there are some things that we do throughout the day, like just as brushing your teeth, where you can get bacteremic, meaning you can get bacteria in your blood. It's very short-lived. Most people don't have any problems. But certainly if you have problems with your gums, with your teeth, you can have constant bacteremia. So you can have constant bacteria from your mouth going into your bloodstream. Not only on your heart, as you said, but also it can go to other joints such as your spine, those areas between your spine bones, but also other joints such as hips and knees and things of that nature. So it's very important to do your routine maintenance. And we have always, from day one, promoted when it is safe, when there are those procedures in place, to go see your primary care doctor or your cancer team or your dentist to have that routine medical care to keep you more healthy in the long run. And I've told this to people before. I have not had people thank me more than when I've been able to get their teeth pulled in the hospital. Because dental health for a lot of people is very hard to come by. It is expensive. It does cause pain daily with eating. It can lead to malnutrition. So I really appreciate all that you're doing to really help with this other routine care for our patients.
Yes.
And we should also note that, there has been other topics, especially around COVID, where people had said, well, why is the World Health Organization different from the United States? Whether that's the CDC or the American Dental Association. I don't really want to say that they're in conflict, but we do have to remember that the World Health Organization has to cater or has to send their message to everybody around the world. Right. And so everybody does not have the physical space between them that we have a luxury of in the United States. They don't have the resources that we do. And so they are trying to make broad recommendations to keep everybody as safe as possible in that community or in that country where you're at. No matter what we're doing, we look at those recommendations, we look at the CDC recommendations, but also the community, the local recommendations as well. Because as we are finding out, COVID really is a community disease. So our community and our dynamics here are a lot different than New York's were, and vice versa. So that is one thing to recognize as well. It's not really in direct conflict. It's just sending the message to different audiences.
I think I read this morning that in the New York Times that there are 4 counties in Kansas identified as hotspots amongst some of the highest cases per capita in the United States, and they're not necessarily all urban counties. In fact, they're kind of rural counties. I know Atchison County was one of those counties, and you look at that, and it really comes down to good infection control. You know, we say the pillars of infection control travel with you wherever you go. Richard, I know you're really good at these kind of things. You work hard to keep folks safe, both here. Talk a little bit about the special challenges in the burn unit, where I know that's got to be a source of concern, and those patients are especially vulnerable.
You know, absolutely. One of the, challenges in the burn unit, and there's no question that we have always been in the burn unit especially sensitive about any sort of infection. The severe burn patients are at significant risk of developing infections both in their lungs and in their tissues. The challenge that we have early on with the big burn patients is that these are emergencies, so we won't know people's COVID status, so we have to treat everybody initially as though they are a potential COVID carrier. If we do have somebody who does test positive, then we've got to be additionally careful when they have any procedures. With the big burn patients, they may undergo several major operations a week for weeks on end while we're getting them through these stages. They also have got tubes, both helping their breathing and then helping with their nutrition, that go through the upper respiratory tract. So, a special call out to sort of all of our burn providers and the nursing team, all of the staff in the burn unit helping with cleaning, because it's a constant source of concern. But I'd say overall in the burn unit, it's really just been an expansion of what is already one of the safest places in the hospital to be, because of the knowledge that they all have with respect to infection control.
All right. Well, thank you very much. And knowing that burn team works hard. Go ahead.
I was just going to say one thing that, about our dentistry group that isn't sort of generally known in the public is that they are an integral part of the transplant program and our cardiac surgery programs. So we won't be able to proceed with some of those without the great work that Dr. Ajamian, Dr. Johnson are doing, and the whole dental team.
Yeah, good, excellent point. Thank you, and glad you guys are all keeping people safe. Jill.
Okay, so Lindsay wants to know, you've been talking a lot recently about patients that are in the recovery stage that are still here in the hospital. They appreciate that, and they want to know what's keeping them in the hospital once they are recovered from
They're
COVID.
recovering.
Yeah.
A lot of times they're still short of breath data.
Yeah.
They have damage to the lung. They may have damage to their heart. They may have damage to their kidneys. They may need to be on dialysis. I mean, there's a lot of different things that are complications of being really sick. They need too much oxygen, more than they can get at home. And it just takes longer to recover after this disease.
Yeah. Oh, you're exactly right. So it is a combination of things. Probably the most common that we see is obviously the need for supplemental oxygen. We have sent people home on it, but certainly, as you said, if it's more than they can even get at home.
Well, right, because once you get over 8 or 10 liters, it's a little technically difficult to deliver that much at home, even with O2 concentrators. But the other problem is when you need that much oxygen after an infectious illness, it's usually more than I'm well and I just need oxygen, which is how people wear oxygen. They're otherwise well when they're at home. When you're recovering, you're weak, and you're having a hard time getting around, your cough is weak, you need help with breathing treatments, you need help with nutrition, and there may not be anybody back at home to do it, and the home may not be a safe environment. Medically safe, I'm talking about, for a complicated patient. So it's sometimes hard, and you just got to get to the point where you're strong enough to be at home.
Yeah, or to your point too, they're just weak. It can be just an overall weakness and need to get stronger. So do you have to go to a facility to work on physical therapy? But is it other things? Did your kidneys take a hit? So did you have some kidney injury? Do you need to just be in here while we make your kidneys recover? Are there new diagnoses that maybe you thought you were healthy? If you were in your 50s, 60s, 70s, and otherwise didn't have any diagnosed medical problems, maybe there's new issues that we have to look at. Diabetes, heart disease. So it's a variety of reasons that people may still be here. Probably one of the most common is going to be needing oxygen and or weakness and needing to recover.
And the hard part of this is very real. This kind of chronic heart problems with skipped beats and weakened heart muscle, which can lead to sudden death. So, COVID is real, and the complications of COVID are real. And we'd like to say our average length of stay is 8 days or 7 days amongst those who are coming in acutely. But when you think about the people who are still here afterwards, it goes up a little bit. I mean, 62 patients in the hospital with one disease right now. Yeah. That just never has. I've been here for 30 years. That has never happened with influenza. So those who are out there still thinking this is the same thing as influenza, just as bad, it's no different, that is just wrong. I mean, it's just wrong. And I can't say it any better than that. It's not true. It's wrong. And what really happens is that with influenza, there are therapies. So there are people who get really sick. But if we have 17 or 20 influenza patients, that's a ton of influenza. Yeah. We have 3 times that many with COVID right now.
And it could be, we certainly, our main goal is to get you out of the hospital, get back to a high quality of life. But we need to, as you said, make sure that it's medically safe for you to be home or wherever you may be going.
Jill.
All right, so Margene and others are asking about reports over the weekend that the CDC numbers regarding deaths had changed, and that they had adjusted it so that out of 161,000 reported COVID deaths, that only 9%, some are saying 6%, had actually died from COVID. She says the community is losing, or people is losing their trust in medical recording numbers. Can you speak to recording of numbers?
Yeah, because it's a lot more than 9%, Dana.
Yeah, it's absolutely a lot more than 9%. It's 160,000 or however many thousand of excessive deaths that did not need to happen, of patients who would not have been ill otherwise.
Who got COVID and then died. And they may have died of a heart attack while they had COVID, or a lung clot while they had COVID, but it's because of COVID.
Yeah, absolutely. And, I think there has been a discrepancy in the numbers since all of this started being reported. Certainly moving from CDC to Health and Human Services and back and things of that nature, there's going to be discrepancies. There's discrepancies in the numbers from the weekend just because of lack of either testing or lack of reporting. Those numbers will all catch up. It's hard to go day by day, and rather than just keep a general concept of really what is going on and look at those numbers. I can't speak specifically about, it was only 9%. It was certainly more than 9%.
Yeah, I can. So if you go to the Johns Hopkins website, they do a really good job. Just follow that website out there. Yep. Unfortunately, what's happened is that the CDC and HHS have kind of gotten caught up in this battle of political ping pong, and I don't mean to make that sound bad, because I don't know that either side on this is right on either side of the aisle, but it does make you lose confidence in what the data is. Here's what we're going to do: we're not going to be flapjacks. You know what a flapjack is? A flapjack are people who flap their arm, they jack with you, and they just kind of have stuff kind of coming out of their mouth. We call that flapjacking. And we are not flapjacks, and we won't be flapjacking. We're just going to tell you the truth. And I think the Johns Hopkins website does. Unfortunately, flapjacking seems to be its own disease, and it's true on both sides of the aisle. And what we try and do is just be straightforward and honest about things. And I would go to the Hopkins website if you have a concern. The New York Times actually reports data from that. That's in the Washington Post. All that information. I think the Wall Street Journal does too. They use those news sources, the original news sources coming out of the Hopkins or the Harvard or other place websites to show the real data. Yeah. And usually you can trust the CDC pretty well, but they are a little caught up in some of that flapjack, I'm afraid. Yeah. Dr. Jameson. I didn't say that right. Dr. Adjamian. I knew I was going to do that at some point. I had a Jameson who was one of my staff doctors back when I was a resident in Rochester, New York. That was a very long time ago. Dr. Adjamian, across the country, Are we seeing cases of patients getting influenza, or not influenza, COVID from a dental office?
No, that I have heard.
I've not heard of it either.
No.
But you're closer to it than I am.
I actually do literature searches all the time, and there's no solid evidence that they got infected at the dental office. One other thing that I wanted to mention is that if patients go to the dental office twice a year, right, we see them more often, and we can see signs of other things. And there's even a sign of COVID on the mouth, on the palate. Sometimes they have this little petechia on the palate, and they don't even know about it. It could be asymptomatic. So if going to the dentist help you find that you have COVID, that would be a good thing. So yeah, I haven't heard of any cases.
The loss of sense of taste or smell, though, that we know that those are real.
Those are real, yeah. But some of the asymptomatic patients can have some petechia in the palate. So you don't look at your palate every day, but if you go to the dentist,
they'll take a look.
Maybe we have
that palate is the top of the roof of your mouth back there.
Yes.
Yeah, my wife thinks I've lost my sense of smell whenever I can't tell that the dog's pooped in the house. She says, "What are you doing with that?" Didn't smell that, dear. Jill, next question.
Donna says that she went to the dentist back in May, not a KU-related office. There's a lot of people that are surprised they didn't know we had a dentist office. And she said the hygienist was wearing 2 masks, although not all the time, and regular glasses and nothing else. She's wanting to know, what do you think the protocol should be if you're going to the dentist? What should you be looking for?
Yeah, Dr. Jamie, and just to say, we've evolved a little bit since then, but I bet your office doesn't do that kind of thing.
Well,
they're pretty straightforward.
There was a shortage of N95 masks.
There was.
So we will have to protect our mask using another mask on top. I think that's the main reason why we're using 2 masks. The shield, in my office, everybody has to use a shield. And I use it here
But
in
you use
the
a mask
hospital.
and a shield. You don't use a shield in place of a mask, to be very clear.
No. We use the N95 and a mask to protect my N95, my glasses, and the shield. Because there's splashes from the mouth into your face. So I use it here in the hospital. I use it in the office. My hygienist use it. Everybody uses in the office. There is a shortage of PPE, and it was worse before, but now we are able to find what we need to protect our patients. So mask and shield.
So we think we got it safe now.
Yes.
And we're in pretty good shape, and our PPE is in pretty good shape right now. So that part's been a lot better.
And now some people are trying to wear surgical masks over their N95 as a way to not manipulate and not contaminate the outside of the N95, because they will be wearing it all day long.
All day long.
So it's another thing that they can do.
Dr. Carntager, I bet you guys work hard at that in the operating room as well. Talk to us a little bit about the efforts that you guys have to do to make sure folks are safe in the OR.
Well, so in the OR, everything starts preoperatively. And excuse me, that's something that we work on with our anesthesia colleagues. So every patient is going to be questioned. When we are booking them for surgery, we're questioning them. Then within the days coming up to surgery, they're going to be tested. On the day of surgery, they have their temperature checked. They're checking, they're asking for any symptoms or anything in the household. So we're doing as much as we can. We also recommend to our patients that from the time that they're tested until the time they come in for their surgery, that they self-quarantine to be extra safe. In the operating room, there is as soon as the anesthesiologists are starting to put the patients to sleep, there's a 6-minute period during which anybody who is not protected with an N95 and appropriate eye protection is outside of the room. And then once that period, that 6 minutes is gone, then we come in and we can begin the procedure. That 6 minutes allows the air in the operating room to turn over. Once we've finished with the procedures, same sort of thing. Anybody who doesn't have an N95 leaves the room while the patient is awake, so that as the tube is coming out, there is as little risk as possible to anybody in the room. We have always done very, very careful cleaning of the operating rooms and all of our equipment in between cases. That just continues. And then in the post-operative phase in the clinics, we're also exceedingly careful. If there is anything where, before the patients come in, they are questioned, temperatures are taken. If we find anything that isn't right, then we will immediately flip them to either telehealth, or if it's something that's emergent, we'll make sure that all of the staff who are involved are going to have appropriate N95s and PPE. So it's always at the forefront. Infection control as a surgeon is something that you are always worried about. So this is really, as I said before, it's sort of an expansion of what we've always been doing.
Megan said she read a story about that plastic surgery, like facelifts and that kind of thing, were more popular now because people can recover at home. And she wanted to know if Dr. Korntager thought that was true, and if the health system does that kind of plastic surgery.
All right. So cosmetic surgery, I think we would call that facelifts and things like that. Are we doing that now, and people recovering at home? Is it safe to go ahead and get that done? I know for a while we paused all that.
We did when we were really concerned about the surge, when we were concerned about our PPE supplies. We absolutely paused all of that. We have resumed cosmetic surgery. We still follow the same protocols that we do with any surgery in terms of keeping people safe. We also have to bear in mind that our primary focus is the reconstructive surgeries. So we make sure that we have the resources to take care of all of those patients. The added thing that we have as a training program is that cosmetic surgery is part of the training that's required for our residents to graduate. So we do have to continue that, and we do think that that's appropriate, but again, we're very careful, and we're always looking at the statistics and looking at the ebb and flow of the COVID infections, and if we need to pull back from that, we absolutely will. There is no question as well in my mind that there is a large demand out there, and part of it, I've had many patients who've said, I want to get this done because I'm working now from home, I'm remote, so my recovery is going to be much easier for me.
So, we appreciate that. Dr. Korntager, I'm glad, because my neck's starting to sag right here. I'm looking older. Can you guys help me with that?
I might get a nip tuck if I have to go on 14-day quarantine and see if I can get in right away.
My neck's... I may need you there, brother.
Ted can help me, yeah.
He's already had to help me out on a few other things, so why not this one, too?
Heather wants to know if you can talk about ways to treat long-haul symptoms, months on.
Yeah.
Oh, that's a cow's question. COVID weariness syndrome. Yeah. And it's a real thing, because when these things drag on and on and on, you get tired of it. Or the flip side is, I think we all get tired of having to be at home and not getting to go out. This weekend, my wife and I were hanging out at home. We took a bike ride, took a long walk, and we were at home outside of the time that I went to go to the grocery store and get the car with gas. And so I think, especially, we're blessed that we get to come to work every day. Yeah. But for folks who are doing everything at home or staying home and your kids are at home, that's just hard. And I don't know that I have easy answers to that, Dana. And you and I have had these conversations with many of our mental health providers. We're going back to have that conversation with folks again, because it's really about trying to find ways to exercise, figure out who's in your bubble, to do Zoom calls, to make sure you have social contact and staying somehow connected to different groups. Zoom tales I've heard of, which are of course just stories, they're not drinking while on Zoom, or maybe it's both. But I think that those are the things that help us diversify our life enough to maintain some interest. And for the long recovery for COVID, which can go on for 6 and 12 months, don't be surprised, because really severe influenza, it is a 6-month recovery. If you've been in the ICU and you've been on a ventilator, it is a 6 to 12-month recovery. And you'll get stronger, but it's going to take a while to overcome the malnutrition and the weakness. Then the key is to exercise, eat well, and try to have contact with people and the loved ones.
Yeah, so even as well as the mental health, we talked about this just earlier on the show. People may need to go home with oxygen. They may have their lungs that are filled up with that cellular free fluid and that inflammation in their lungs, so they need the oxygen. That will hopefully go away in some time, and that will reabsorb and your lungs will function normally, but you may still need that oxygen for 60 days, 90 days. You may still have some extreme weakness for 60 days, 90 days.
Or 90, it may go into 6 months.
And it may go further.
Yeah,
Yep.
it could be 6 months
So
after an ICU.
it's a matter of getting out, doing that exercise if you can, continuing any therapy techniques if you're having the weakness to get stronger. The sense of taste and smell, it could come back in a week or two. It could last 6 or 8 weeks. So it's just individualized, but you just have to keep being vigilant on your recovery efforts. Some things you can't control, cough. I've seen a patient who was in the hospital for a week, went home, felt really well, but just continued to have a cough. That will hopefully resolve, but it will take time, and don't get too frustrated over it.
Okay, one last question, Jill, and we'll have to wrap up.
Barbara is in a dilemma. She can't pass her second COVID negative test. She feels good, wants to go back to work. How does she get help? Can a health
That's a
department help
great
her?
question.
Or?
Well, the COVID-19 you can shed for a long time, but you're not infectious now.
No.
There's in some work requirements still say you have to have a negative COVID test,
Yeah.
which is probably, unfortunately, that becomes a false dichotomy, meaning that you may shed the virus for a long time, even when you're not infectious and you're totally safe. But the work requirement may be different than that.
Yeah, I think, we don't endorse retesting. We certainly don't retest our patients nor our employees that have been tested positive in the past. I think it provides a false sense of hope, but really what it does for that person is probably add more to cows,
It
to the
does add more
weariness
to
syndrome,
cows.
because we know you can shed for 60 days, 90 days. So I think maybe looking at that protocol or looking at that system, and why are we testing again? Do we really need to test? Because we know after you're positive you can shed. But if you are that 10 days out from your diagnosis or that 10 days out from your symptom onset, you really should be able to go back into society again, continuing to wear the mask, physical distance, not meet in large groups, and do all those things that we've talked about.
Yeah. All right, so Dr. Corentage, your final thoughts today?
No, I just think we need to, exactly what Dr. Hawkinson was just saying, we need to be vigilant, we need to take this seriously, and we need to support each other through this.
Yeah, exactly. Dr. Adjemian, I said it right.
Yes, same thing. Just keep wearing the mask, keep wearing with the social distancing, and take care of your health as well as your oral health.
Thanks to you again. Most patients love when you're able to see them in the hospital. Continue to get your routine medical care. That includes dental care. That is extremely important. All of our clinics have those procedures in place, KU Dental, KUI. We are really committed to protecting you, the patient, and also our employees and loved ones associated with our employees and the patients. So it is very safe. Continue to get your primary medical and your preventive medical treatments.
All right, so tomorrow, a special program again. You may recall the video clip we shared of Scott and Shannon Brugge from Lawrence, who shared their COVID-19 story. They're going to join us along with their physicians, a pulmonologist, Dr. Krishna Ranja. I should know Krishna's last name. He's a fellow here. Good golly, Miss Molly. And also infectious disease specialist, Dr. Christopher Breichel. These are really important times. And as we finish up the program today, I want to say thank you to Dr. Corentage and thank you to Dr. Adjemian for being with us this morning and talking and addressing these things that are so important to all of our listening audience. Here we have a few pictures of masks, and I love the Chiefs gear. Let's go, September the 10th. Jennifer sending these great mask moments of family on a trip to Colorado, where they say the masking and mandatory cleaning protocols were great. You know, the Colorado's a Wild West, yet people always wear masks there. Zip lining and funning at Snow Mountain Ranch, YMCA of the Rockies. I love that place. So send us your mask photos. Those are the best, and I really like seeing the Chiefs gear around Bronco territory. That's really good. What's not really good is flapjacking, right? If people can just tell the truth, we'll all be better off. COVID is hard enough without folks trying to flap their arms and jack with us and not tell us the direct truth or changing the stories or just not being honest. I would ask that all of us try and do our very best, because otherwise cows get worse. We don't need to have any more COVID weariness or be weary about what the truth is. Being honest is something that in medicine we should do that every moment of every day with our patients and their families. Otherwise, how can you believe the physicians, and how can you believe the staff and the nursing team and the recommendations that they give you? That's the same thing we should ask of each other. No flapjacking, just the truth, so we can all handle this cows together. Because when we handle things together, we are that much stronger. And remember, wherever you go, the pillars of infection control, they travel with you. And if you'll just remember that, the flapjacking goes away or comes to a minimum. Cows can be minimized because we can keep each other safe. So until we see you tomorrow, remember this: there's still no place like home. We'll be back with you tomorrow.